Hello, my name is Angela Pontifex. I'm a continence and pelvic health physiotherapist from Perth, Western Australia. It's a privilege to present our paper to you, which is entitled, How Might We Screen for Psychosocial Factors in Individuals with Pelvic Pain, an e-Delphi study. This project was conducted as part of a Masters in Clinical Physiotherapy, Continence and Pelvic Health program in 2019 at Curtin University. We did not receive any funding for this project. Firstly, to set the scene, I will define chronic pain in the context as it relates to the pelvis. The European Association of Urology defines chronic pelvic pain as non-malignant, continuous or recurrent pain in structures related to the pelvis, lasting at least 6 months and often associated with negative cognition, behavioural, sexual and emotional consequences. I'll refer to this condition as PPP or persistent pelvic pain from here on in. PPP affects up to 25% of women and 8% of men worldwide. The primary care presentation rate of PPP is about 3.7%, which is actually comparable to lower back pain and asthma. A review in 2014 reported endometriosis alone costs society about $7.7 billion here in Australia and about $78 billion in the US. And it's estimated that the total annual cost of all PPP conditions exceeds $150 billion a year just in the United States alone. PPP conditions are complex and are often caused by dysfunction in one or more body systems. They're associated with pain-related cognitions, including catastrophizing, fear of pain and intimacy, depression, anxiety, and self-efficacy. Thankfully, these are modifiable, with multiple guidelines recommending screening for these to guide appropriate treatments, signal early referral and monitor progress. As clinicians, we should all be aware of the many validated screening tools available which individually assess these variables in persistent pain conditions. However, none of these have been designed for pelvic pain, they are lengthy to administer and do not combine all variables into a single form. The convenience of a single screening questionnaire may encourage its utilisation, improving the detection of these influential variables. Therefore, the aims of this study were firstly to determine the psychosocial variables that require screening, and secondly to determine the most appropriate statements to screen for each of these psychosocial factors individually. We recruited a heterogeneous panel of 14 experts to be the participants in this study. They included 8 physiotherapists, 5 psychologists, and 2 medical practitioners from Australia, the UK and Canada, with an average of 17 years experience working in the area of persistent pain or pelvic pain. The study design was a 2-part modified e-Delphi technique. Part 1 commenced with a literature review followed by an online focus group where the aim was to determine the psychosocial variables most relevant and the screening tools that best detected these variables. Part 2 was a modified e-Delphi using the knowledge and experience of the expert clinicians. The aim of this part was to establish consensus regarding the individual statements for inclusion in the final screening tool. This was achieved using the variables from the focus group over 3 online surveys and 2 teleconferences. These are the results from Part 1 of the study. Outlined in blue on the left are the findings of the literature review, which identified 7 psychological variables, catastrophizing having 3 subvariables, which were presented to the focus group. The focus group was asked to determine if these variables were indeed predictive of treatment outcomes in PPP and identify any other variables they believed to be important. Verbal consensus was reached for an additional 4 variables. They are highlighted in light green. The group was then asked to determine the best validated questionnaires that would assess each of these variables individually. All statements from these questionnaires were collated into one online survey which created Part 2 of the study. In Part 2, the experts were sent a link to this online survey in which they were asked to distribute 100 points across the questionnaire statements for each psychological variable. Higher point allocation was designated to items that better captured that particular variable. Experts were also given the option to reword those statements or suggest new statements if they felt the original questionnaire statements were not sufficient for this population. We analysed both qualitative and quantitative data after each round of the survey. The survey scores of each statement were analysed using both medians and interquartile ranges, which have been shown to be objective and rigorous measures of consensus. Items were eliminated from the survey if they had a median of 10 points or less and they reached a consensus. We also used the Wilcoxon matched pairs signed rank test to determine stability of each of the statements between the rounds. At the beginning of round 1, there were 118 original statements included in the survey. By the end of the third round, there were 15 statements remaining, which form the screening tool. 6 statements came directly from previously validated questionnaires. 2 statements were reworded items from round 1, and 7 statements were new suggestions from the panel. Here is a list of the final psychological variables and their relevant screening statements that form the new screening tool. Our study is the first to thoroughly investigate the most appropriate variables to assess in individuals with PPP. This expert-informed list will form the foundation for creating a new screening tool to detect psychosocial variables in individuals with PPP. This screening tool will allow practitioners to make more informed decisions regarding patient management, promote psychologically informed care and multidisciplinary management, and change patient trajectories to more positive outcomes and improve quality of life. Thank you very much.